maybe because of some sort of muscular dystrophy, some maybe due to trauma. All these may come into this locomotor disability type of things. There is again, you can see the number 11 item is a muscular dystrophy, is a specific entity which usually occurs in toddlers and a little bigger children. Then some diseases like multiple sclerosis, which comes in the elder age of elderly people, or maybe in the after the age of 40, that will come up. Dwarfism is one of the things that is very difficult to define even, because the standards that we use to check the height and giving a definition of dwarfism and the causes of dwarfism are spectrum. So it is a little bit difficult to identify or maybe put into a particular area. And the support systems for dwarfism also are not really uncovered properly. So again, coming to one other condition called cerebral palsy, which is very common, which is the one that we all are very familiar with. But the problem is that what can be done on cerebral palsy with regard to improving the social systems or social settings is not that fully understood. There are a few diseases like thalassemia, hemophilia, and sickle cell disease. These are not that common, but they are put under the rare diseases category. But again, the way that disability comes into all of these are in different ways. Like in a hemophilia patient, as you know, it's a bleeding disorder and it's a genetic disorder. Every time there can be a chance of bleeding in joints, like knee joint, maybe shoulder joint, maybe hip joint. So every joint can cause some sort of disability by putting some movement restrictions. And most often what happens, we identify very late. By the time, most of the time, the child or maybe the patient will have some programs in the recent past that has come up with some prophylaxis with factors, replacing factors for patients with, or maybe children with hemophilia, and trying to address it. Similarly, for sickle cell disease, again, sickle cell crisis is one of the reasons that causes the blood flow will be limited to joints, and there can be some bone damages that can cause disabilities. Then blind and deafness, blindness, low vision, all these things. The leprosy, you know, it is a historic disease causing disabilities. Then hearing impairment, of course, that is one area. There is a lot of activities happening for the last 2 decades. Then whenever we say disability, nowadays we go to autism spectrum of disorders, the number 9, and the most work happen globally is on mental illness and intellectual disability. So these are all very, very common conditions, other than the acid attack victim, which is came as a socially relevant part. So this is all about the RPWD Act, which is the central key pillar where we'll be talking about for the next 20 minutes. So when we talk about disability, I'm forced to talk, or I'm forced to remember the most most successful person with disability, Stephen Hawking, and it is something like a superhero And of course, in the literature, everywhere it says uh, these people who have succeeded in life, who had disabilities, are actually a good thing, but at the very same time, it is one of the limitation um, because the most of the time we will not consider the resources, maybe the education of parents, maybe the other things, the money that they have, all these things around them, which of course help them to prove in their life, or maybe in other words, they were able to overcome the disability. But even whatever it be the condition, there are so many. There are so many, from Helen Keller to Stephen Hawking. They have come out of these sort of the limited abilities to show people that they can do wonders, and they can do better than many others who have no disabilities. So this is one of the quotes by Stephen Hawking, and I would like to focus on the last sentence. The governments everywhere can no longer overlook the hundreds of millions of people with disabilities who are denied access to health, rehabilitation, support, education, and employment, and never get a chance to shine. So this is one of the thought for the last 2 decades, and we must understand that even the poorer countries, being the part of the UN agreement, has done a lot of things, especially in our country, and most of the time, the better states, better performing states like Kerala in India have done a lot of things in this particular domain. And we won the national award last year, and the Honorable Minister for Health received it from the President of India for the most friendly, the disabled friendly state in the country. Even in that case, there are so many things to be done, and there are so many gaps. So I hope we all together will be able to contribute and make our state again better, and for doing good for maybe the children, or the adults living with disabilities. So particularly, I'm dealing with this domain under 4Ds. We can see defect at birth, deficiencies, the diseases, childhood disease, and development delays and disabilities. So this is the program that we call RBSK, Rashtriya Bal Swasthya Karyakram, which is started in 2013 as a national flagship program with an objective to limit disabilities among children. So the strategy is early identification and early management. If it is not even management, most of the time for developmental delays and disabilities, we usually say early detection and early stimulation, which is the one that will work. In this 4Ds, mostly we can look at two of these: defects at birth and developmental delays and disabilities, both things that shown in gray. The others are mostly diseases and deficiencies, where even though they can result in some of the disabilities, but mostly the other two categories are contributing to disabilities. Especially, say, the first one, a neural tube defect, which is a congenital problem, it's a genetic condition. Can be due to some deficiency also. If the pregnant woman is deficient in folic acid, the baby can develop neural tube defect. What happens in this particular neural tube is the structure that from where brain and the neurons develop. So if the proper development of brain and neural structures is not happening, there will be some sort of disabilities. So if it is not managed properly, and the most difficult situation is that managing that condition, maybe the surgery that to be done. it is a very highly specialized care that will have to be provided to the child. And unfortunately, we don't have that much of facilities even in the state of Kerala. Then you can think about other states. If some child born with neural tube defect, most often the child will end up in paraplegia or maybe something like that in future, and mostly they die before the age of 3 or 4 years. If they happen to survive, there will be some definite limitations, especially in moving. Then cleft lip and palate, which are very common. That is, we see cleft lip and palate in 1 in 1,000 of every birth. 1 in 1,000 of the birth, we can see cleft lip and palate. So what happens in cleft lip and palate is that the speech will be affected, and that itself is a problem for the child during the growing period. They will have some sort of difficulties in social interaction. Social inclusion will be limited. So all these, the stigma related to all these conditions, all these are problems. I'm not going into each and every condition in detail, but these are the 9 defects at birth usually contributing to most of the disabilities which we'll be seeing in category 4, that is the developmental delay and disabilities. Particularly, we'll have to look at cognitive delay, which is one of the area mostly discussed nowadays. And the most important limitation we have at this point is expert. We don't have that much of expertise in the field of dealing with cognitive delays. We don't have people who have gained knowledge and experience in dealing with children who are having cognitive delays. So that is a real challenging area. That is one area where, and that I must say, that is one scope for social workers. When you are doing your specialization, definitely you can think about dealing with children having cognitive delay, even though may not be the part of your curriculum, but of course, during your dissertation and other things, you can look into the conditions of cognitive delay and how to deal with this, because this is a growing area and it's going to be one of the domain for the coming decade. Then, who are the high risk and vulnerable among children? So, looking at the 2011 census and NSSO reports, there are some alarming numbers, like 184 per million people in the country in urban area, and 149 per million are having some sort of disability. So altogether, they contribute to around 1.4 crore in the total population of 131 crore. So this is a big number that to be addressed. Among that, if you look at the children, the group of children are around 20.42 lakhs. That too among the 0 to 6 group, they are disabled in one way or other. And thus, even the word disabled we don't usually use for children. We call them as special children, the children with special needs. There's 1 in every 100 children in the age group of 0 to 6 suffer from some type of disability. Then around 23% of the disabled children, that is 0 to 6 years, are having disability in hearing. So the mostly identified, or mostly they are the most one who may survive without any other problem, and they will live longer than any other children with disability. So out of this 23% are with hearing difficulty, 30% are having vision problems, and 10% with movement disabilities, and 7% disabled children have multiple disabilities. So if you look at the whole birth cohort, around 6% of children born every year will have some sort of disabilities or maybe some birth defects. So this is the way it comes, and there are systems in place to identify this even before birth in utero. And some of the non-viable conditions are usually getting aborted in developed countries, but we don't have that sort of a system developed in the country. There is no male or female preponderance for disabilities that we have noticed as per the census data. But some other areas, which is some of the slides that I'm coming up, we can see there is a little bit of difference in dealing with the male and female children by the society. There are some differences. So before going to this, who are really the high risk group and why the high risk group is increasing? The reason being the survival has improved. When we talk about the country, the infant mortality is 32 per thousand. That means 32 children, 32 infants die before the age of 1 after the birth. But in the state of Kerala, it is only 7. So you can see the difference. So even there are only 7 children, 7 infants dying before their first birthday. That means 993 are surviving. Does it mean all the 993 are surviving alike? No. Many of them have some sort of disabilities or problems. Earlier, in maybe 20 years back, many of them would not have survived, but now they're all surviving because of the improved facilities. At that point, it is our responsibility to provide the environment to be conducive for their the improved quality of life for these children also. So mostly the preterm, the baby is born before the term, like the 40 weeks is the term that usually a pregnancy will have. And who are born before 37 weeks are called preterm. Maybe very preterm babies also survive nowadays. Around 28 weeks or 30 weeks pregnancy, 7 months we call, they all survive nowadays. Even a baby with 1 kg or maybe a baby with 650 grams survive in our state usually. So all this contribute to the increased number of children nowadays living with some sort of disabilities. And the reason could be we are not able to provide that environment which is conducive for these children to survive rather than the baby is born at term and with good birth weight. So this is one area that the health department right now is focusing on. So these are some of the statistics that I've noticed from the NSSO and the 2011 census. Out of the 61% of the disabled children 5 to 19 years are attending education. No option to attend the schools. That is one relevant area to be addressed. 54% of the disabled children with multiple disabilities never attended educational institutions. So we saw 7% of the total disabilities in the earlier slide. 7% of the children or people living with disabilities have multiple disabilities. Out of that, 50% have never gone to any educational institution. So even though that number is not that significant, saying that 4% or 3.5%, but that says something. There are some blocks for them to go to the normal social environment. Going to an educational institution is something very right in the country, but that is not fulfilled even though it's a small percent. Also, 50% of the children with mental illness never attended educational institution. So again, the last slide I point out 10% of the total disabilities are mental illness, And out of that 50%, that means again 5%. So altogether around 10%, 5 plus 3.5, 8.5, that's around 10%. They have never gone to any education institution. Even when we say 61% of the disabled in the age group of 5 to 19 have somehow attended an education institution. But there are a group, there is a significant 10% that have never gone to any other institution. Of the total disabled, only 55% are literate. That is also worrying about the 2.41 crore, the 1.46 crore I mentioned earlier. Out of that, 55% are only literate. So even in the state of Kerala, when we say we are fully literate, we'll have to look at the data specifically for Kerala. What is happening to these people who are disabled? Among the total disabled persons, 45% are illiterate. That is the other number to 55%. So 45% are illiterate. 13% of the disabled population has metric or secondary education but are not graduates. So and 5% they are graduates and above. So even though 55% are literate, there is some blocks. There are something which is this, maybe the social situation, maybe the financial position, maybe not the country's environment around them, limiting them to go beyond some levels. That and they couldn't go for a graduation. Only 5% of these are graduates. So when 55% are literate and when we say 61% had access to educational institution, and we say 5% only are graduates, that definitely says there is some problem in even the education sector. Sorry. So when we look at the all India level, 36% of the total disabled persons are workers. That's good. They have a living. They have rehabilitated. But at the very same time, you can see among that 47% are male and 23% are females. So that's again says some disparity when or a gender discrimination among disabled when they go for some sort of a working or maybe trying to earn and live a life of their own. There is again a rural-urban difference. Even though there are more cases reported from urban centers, the urban area that I have pointed out, 189 per million, 184 per million, and only 149 per million in rural area. In rural India, 25% of the female disabled are working, while in urban India, the corresponding number is more than that. It's only 16%. So, sorry. So there is some factors influencing all these things, which definitely we need to address, and that can only be done through some sort of looking into the data, maybe some research, which I'll be coming to that aspects where what a social worker can do in my later slides. What is the role of RBSK? Of course, I pointed out our role in RBSK is to limit disabilities, maybe to identify that at the earliest point, and the process of rehabilitation of disabled starts with prevention and early identification, of course, intervention and integration. We need integrated efforts among the departments, different departments we have. And I'll be coming to that in the next slide. So that the rehabilitation and assimilation should happen at the end, which is one of the major role that of course should come up. Maybe not that much focused at this point, to best of my understanding. Social workers challenge social justice. That is what we read and learn. So social workers pursue vulnerable and oppressed individual and groups of people. So this is one expectation from social workers in dealing with the social challenges, or maybe the people with disabilities, which I tried to point out in the last couple of slides with some statistics. So you must be aware of the National Program on Rehabilitation of Persons with Disabilities, NPRPD. This emphasizes on community-based rehabilitation. One of the changes that happened over the period of maybe last 5 decades. Earlier, everything was based on sympathy and charity model. When we talk about disability or people with difficult living conditions, everything was based on sympathy to empathy and opportunity level of or the models like empathy and opportunity models. That means it's moving away from a passive reaction to all these things to an active model where some proactivism has come up so that building confidence among people with disabilities so that they can also have a feeling that they can also do things may not be as similar as that any other people, but they can also do justice to their life and do wonders, as I pointed out earlier with some examples. There are not anecdotal, there are a big group of people who have succeeded in their life. So another way of approaching disability was through a medical approach. We usually call it a medical model, where a medical doctor uh, dealing with the people with disabilities and rehabilitating. And that has also moved to a social model where the doctor is involved. Maybe more than that, a social setting is created. Uh, the UN also has come up with such a model called community-based rehabilitation, where the social involvement is getting improved, so that the changes in environment rather than the individual-based care by the practitioner on rehabilitation is the one that we are looking at this point. The role of NPRPD is integrating all the national programs or policies in the area of education, information technology, transportation. Uh, all should at least address the needs of people living with disabilities. Um all of the PWD should get some sort of a rehabilitation services. Then, of course, create awareness on preventive aspects in the society, both in the medical and paramedical professionals. Um, the, we need a lot of, looking at the country with a population of 131 crore and a huge area with around so many states and diversity of living conditions. The infrastructure building is a very difficult area, but we need to improve the infrastructure to assist health education, the Panchayati Raj level welfare systems, the rural development organization, all these new infrastructures to be come up, and there are strong legislations that have come up, and even in the local self-government, there is a mandatory contribution to be put up for the management of these conditions, or to support the people to get their projects approved. Then access to appropriate education at preschool, primary, and secondary levels, and also nursery support systems beyond that. This is one area, the gray area, that even now we have. There are anecdotal conditions where people have come out of their disabilities. As you know, the sub-collector of Trivandrum now is a blind person who has reached one of the highest levels of aspiration any youth has, um, securing an civil service position. So there are cases, but we need the environment to be built up for more people to success in their life or succeed in their life. Then make education child-centered rather than the common educational platform. Most of the time, uh, may not suit a child with some sort of maybe even minimum disabilities. But the only thing that we can do is make the education child-centered rather than for any child, even though the child is not disabled. This should be the way of approach for education. It should be child-centered. Special and inclusive education and suitable teachers training programs to be made part of it. You know the resource centers that we have, block resource centers, and other systems in place at ground level, who have been trained especially to deal with these sort of children, identify the cases, and especially the SCRT in Kerala is doing a lot of work in this particular area, but they need to be supported by the social systems in place. So it will be very difficult to leave the topic without mentioning the Sustainable Development Goal 2013 till 2030, which aims at leaving no one behind. Almost six, seven mention. I think around there are around 11 mention about disability in the whole SDG goals. And I'm just pointing out few of the major ones. SDG 4 is aiming at guaranteeing equal and accessible education, where the this particular group that we were discussing, we should also be focused if you want to leave, if you don't want to leave anyone behind. SDG 6 is for promoting inclusive economic growth, full and productive employment. So here is one area where we told only 36% of the disabled are working. So we'll have to include, or maybe the economic policies and the labor policies should be modified so that more can be included. SDG 10 is for emphasizing the social, economic, and political inclusion of persons with disabilities. This specifically mentions something about disabilities, people with disabilities. SDG 11 is for creating accessible cities and water resources, affordable, accessible, and sustainable transport systems. You know, even in our state, it will be very difficult for somebody to travel, and not in public places, but even their own houses. It is very difficult for a person with disability, even though we can give crutches or maybe the wheelchairs. It is very tough for somebody to survive in our conditions. And the good thing about that is, I happened to see one of the exhibitions which happened a year back in Thrissur, where a lot of innovative products were demonstrated by people and some of the companies. Even people can walk around their compound, even though the surface is not even. So, so all these are coming about, but the cost factor is a challenge. And we have the routine thing that we usually see is the tri-wheeler, which will the panchayats or maybe the departments are providing to people, and people traveling from one place to other in the kinetic Hondas, the sort of thing that we have started seeing from maybe last 10 years. But there are more things that is coming up nowadays. And SDG 17 is for disability disaggregated data. So the role of data, I can tell you the role of data is very important, and one of the area that even the professionals can deal is, or maybe start working, is looking at the data and how to process data. So this is a big data. Big data set needs to be analyzed. Um, so if I'm a statistician, what is the relevance of a social worker looking at these particular set of data? That I'll try to just say in few words. Like if I'm a statistician, I have the expertise to look at the data and say that this is this and this is not the other one. Maybe the data coming up is significant or not. But when a professional who is dealing with that particular setting looks at that data, you will be able to see a lot more than a normal statistician or maybe somebody who is not working in the domain looking at that data. So you need to improve your skills and capacity to look at the data. Then only you will be able to come up with, or maybe even point out some of the deficits, and you will be able to come out with some solutions. So this is one particular area that definitely you should be able to work and gain knowledge and skills. So, coming to the point, the scope of social work in disability settings. There are different settings where social work can deal with. The mostly that one we see is the healthcare setting and education. Maybe a little bit in early intervention services and mental health services. The child protection is an area where there are some sort of involvement that we are seeing for the last 1 decade, but not that much into the children with disabilities. But as you know, the areas of POSCO, gender, and other issues. But of course, this is one area where the social worker can start looking at, gain more knowledge, better awareness, so that you could be able to do a better job in even in your profession that you are currently doing. So, but some of the other areas I would like to point out is policy and research, and even in justice services, uh, the legal obligation that most of the time that we need to provide, or the the new legal services that we'll have to come up with, or maybe the systems to be built up in the legal settings or maybe creating a conducive environment for people living with disabilities. The other one, of course, that's most important, I believe, the policy and research. The research should happen in the area of people living with disabilities and the scope of social work. Then only we will be able to come up with new policies, and the policies will lead to decisions, and the decisions will help you to implement things. The pillar stone here is research. You need to start working in this particular domain. Mostly we do the rehabilitation service, or we just try to get into a job. In that area also, I have my experience. And I must say sorry to tell this. Many of the time, the professionals who are coming are not properly trained to deal with that particular setting, or maybe as per the requirement, or maybe as per the global standards or the current standards that are prevailing. So there is definitely a scope for even the professionals working in education sector, dealing with social work, or maybe the students who are in right now in social work courses should try to have your future objective very clear at this point of time itself, and you can specialize on some of these areas. If you want to have something to engage in rehabilitation services, of course, you need to gain knowledge and expertise, some sort of capacity building, maybe by working in that area, or maybe taking some time for getting exposed to that sort of things. To have your skill improved, or maybe your knowledge improved, so that when you are going for a job, you should be able to contribute and help the people who are in need. Then, of course, which is very limited in our settings. This usually happens in a global scenario, mostly in the European countries. We don't have such linkage systems at present, and everything now is being linked to government and government programs. Unfortunately, we don't have that, so that not that many NGOs working in the domain. Very limited numbers and not much when we compare the need and the provisions. So this is one sort of an area that maybe as a professional you are coming up with an NGO, you can try to work with information linkages and capacity building programs for professionals, or maybe different set of professionals working in this domain. Advocacy, of course, is a major area that you can try to work with, because we need advocates. We need advocates who talks about people with disabilities, the limitations they have, the gaps in the systems, the gaps in the environment, and at the very same time, not only pointing out the demerits or the defects in the system, but coming up with new ideas and solutions for um, uh, people living with disabilities. So I think I'm coming to the end of my session. Uh, this is some of the course that I have taken. Maybe some of the when I read these are some of the references I have. Social work based its intervention on a systematic body of evidence-based knowledge and practice. If it is so, we need to work a lot. And we need to work hard and prove it. The primary area of social work intervention is therapeutic work. Uh, I have a little difference of opinion in this. Even then, uh, we need to focus on systems building and social system building, or maybe the making the environment more conducive uh, by trying to engage more people around you for making the change. So I think the social worker can be the best change maker, and the social engineering should come in place, and definitely you'll be able to contribute. Maybe it is controversial, but it is my point to make. Social work theory and practice in the field of disability has been greatly influenced by values and philosophy of independent living movement. Yeah, of course, it is true, but we need to go beyond that. Uh, the I value the values and philosophy of the independent living movement, but we are living in a society, and earlier I pointed out that the system itself has moved away from the medical model to the social model, where the social system needs to cope up with the needs and requirements of people living with disability. So thank you for listening, and I'm open to questions.
Thank you very much, sir. Thank you for such a wonderful session. Now the floor is open for all discussion. Post your comments in the comments or you can unmute your
Pardon, I didn't hear anything. If you have any questions, please.
Is there any questions?
More than questions, I value your opinion, or maybe if you have anything to point out.
Sharif, are you talking? Sharif? No. Okay, actually, today we had very good participation. I couldn't admit everyone. Actually, nowadays Google Meet having some limitation. Formerly, it was 250, but now it is limited to 100 only. So there were many participants that were waiting after starting our program. So we were having live streaming. So I shared in many of the groups, including Mercy groups and all. I came to know that we are having participants from various colleges here. I can see many students from St. Mary's College, Trishur, and Nazi College, and some professionals also. Thank you, everyone. And now I welcome Shilpa of second MSW for proposing vote of thanks. Shilpa?
A very good afternoon to one and all. It's my complacency to bequeath the vote of thanks of this astounding knowledgeable session. I would like to express my immense gratitude to the chief guest, Dr. Srihari M, for his knowledgeable words. Last but not least, I would like to thank all participants, including the dignitaries. Thank you all.
Thank you, everyone. So our next webinar will be on 29th. That will be on cancer awareness by Dr. Nadran sir. So welcome all. I will post I will keep on updates about our webinars in the respective groups. Thank you, everyone. Thank you, Srihari sir. Thank you very much.
Thank you.